Hi, my name is Tracy Tibbles and I currently work as the Podiatry Manager at St Vincent's Hospital, Melbourne. The clinical objective of the Podiatry Department is to reduce and prevent hospitalisation and emergency presentations as a result of foot complication. According to the Diabetic Foot Australia website, every 3 hours in Australia, a person with diabetes has a lower limb removed as a direct result of diabetes-related foot disease. Diabetes-related foot disease is caused by a number of complications such as neuropathy and peripheral vascular disease. These complications are directly related to poor glucose control. Diabetes self-management education has been shown to improve glucose control and reduce glycated hemoglobin levels. Self-management involves self-monitoring of blood glucose levels, medication adherence, and lifestyle factors such as healthy eating and increased physical activity. Mobile health applications have been shown to have a number of potential benefits to assist patients in facilitating their self-management of diabetes and potentially improving clinical outcomes as a result. Mobile health, or mHealth as it is known, is defined by the World Health Organization as medical and public health practice supported by mobile devices such as mobile phones, patient monitoring devices, personal digital assistants, and other wireless devices. A literature review was conducted to assess published studies which reported on the use of mobile health applications to promote self-management in patients with diabetes. A search was conducted using the following databases: Cochrane Library, CINHAL, PubMed, Scopus, and the Joanna Briggs Institute of Systematic Review. Only articles published in English between January 2015 and June 2017 were included in the search. Articles were selected according to title and abstract. Articles were excluded if they did not focus solely on patients with diabetes or were not relevant to self-management or mobile health. Only articles that were published in peer-reviewed journals and were available in full text were included in this review. My top 5 articles were chosen for the following reasons. Studies were related to a population cohort of participants with both type 1 and type 2 diabetes, that there was a focus on measuring self-management parameters, either behavioural or physical health outcomes. Articles that were selected gave an overview of a number of mobile health applications, and research wasn't limited to one specific brand of software or program. And considerations for future mobile health implementation was detailed. The quality of evidence was also a consideration, with systematic reviews and randomised control trials being the preferred study designs. Finally, the last article was chosen as it demonstrates what can be achieved with a personally controlled electronic health record in relation to patients with diabetes. This study conducted a systematic review of clinical studies relating to the use of phone applications for diabetes management. Original articles from 2007 to 2014 were searched in peer-reviewed journals with analysis conducted on the study type, duration, sample size, age of participants, type of diabetes, technology used, and overall study outcomes. 21 articles were reviewed and grouped into the following categories: diabetes management, patient education, or patient behaviour modification. Studies focusing on management were primarily diary-based applications designed to help record information such as blood glucose levels, food intake, and exercise. Overall, there was a significant improvement in glycemic control. However, due to the lack of studies with a duration of greater than 12 months, the authors questioned whether compliance with these applications will wane in the long term. Studies focusing on patient education in the form of SMS or app notification also found a significant improvement in glycemic control, with varying levels of improvement in other outcomes such as blood pressure and lipid profile. Once again, studies were limited to a duration of 12 months, and the authors argued that the lack of active engagement required by the user may adversely affect outcomes in the longer term. Phone applications focusing on behaviour change reported varying levels of lifestyle modification, with only 2 studies reporting significant improvements in glycemic control. Duration of study was also a limiting factor in this group, with only 1 study conducted for a period of greater than 3 months. Overall, this literature review focused on a number of self-management parameters and gave an overview of a number of phone applications. studies discussed related to both patients with type 1 or type 2 diabetes. Limitations of this study included the absence of studies conducted for a period of greater than 12 months, the absence of considerations for digital health literacy, which may have confounded results in older populations, and cost analysis of applications were not included. Another major limitation is that the studies reviewed were from 2007 to 2014 and may not reflect current evidence. The number of phone applications available in 2017 has almost doubled since 2014. This article conducted a literature review of published studies from 2014 and 2015 to illustrate the use of digital technology to manage diabetes by enabling consumer engagement, behaviour change, and the collection of digitally obtained data. It identifies 16 articles which the authors believe highlight the future directions of mobile health in diabetes. Key findings for success were self-management programs need to be designed to promote engagement from users. Two ideas to achieve this are allowing participants to self-tailor their experience and providing interactions with other individuals for peer support. Patient satisfaction with self-management applications were primarily associated with two factors: the usability of the device and their improvement in diabetes. Patients also valued easy-to-use programs and those that facilitated support from healthcare providers. Studies also found that for successful implementation, applications not only needed engagement from patients, but also from healthcare professionals. This allowed support for the users and supplemented their experience. This study identified the limitations of smartphone applications. Whilst there are a large number of applications available for Apple and Android users, the majority of these apps offer similar functions. There is often only a small number of functions that each app offers, and patients are required to download 2 or 3 apps to record information such as blood glucose control, food intake, and exercise information, which supports their self-management goals. Another challenge associated with self-management apps is their ability to motivate people to use them. The authors speculate that it is highly likely that these apps may only work for highly motivated patients who actually do not require health behaviour change. As with Article 1, one major limitation with this review was that no study was conducted for a period of greater than 12 months. Overall, this literature review identifies that the use of self-management applications can yield positive outcomes over a short term. It highlighted important considerations for implementation of programs and the value of the role that health professionals can play in this interaction. This study explored the impact of digital literacy on self-management and the adoption of mobile health. A pilot program of 28 participants with type 2 diabetes were invited to use iPads over a period of 10 months. Participants were of equal gender and varying levels of age, education level, income, and diabetes duration. Half of the participants were aged between 50 and 70. Digital literacy also varied, with 9 participants classified as non-users and either did not own a computer, mobile phone, or use the internet prior to the study. iPads were installed with a number of applications designed to facilitate 6 self-management activities: recording food intake, journal keeping, communication with other patients, recording exercise, checking blood glucose level, and information seeking. Participants were not required to use any of these applications, with the purpose of the study being to observe how they use the iPad in their daily lives. Participants were required to attend 1 mandatory group training session. After this, participants had the option of attending extra group training sessions or requesting individual sessions to support their application use. The project found that those who participated in extra training sessions actually use their iPads more frequently and use the apps to manage their diabetes. There was no difference between mobile health application use in participants who were identified as being skilled or unskilled in technology use prior to study commencement. Confidence using the device and applications was not surprisingly higher in participants who had attended the additional training sessions. The most frequently used apps were found to be for blood glucose level tracking and information seeking to find nutritional information. The least common activity was communicating with other patients. Patient surveys were conducted at 2 months and 5 months and found that the majority of patients were satisfied with the application's ability to help manage their diabetes. Even though this study had a small number of participants and did not mention any physical health outcomes, it highlights the importance of training and continuous support to increase user confidence and digital literacy. This confidence was found to increase user engagement and motivation in the use of the health applications. This article conducted a literature review on digital health use to promote diabetes self-management. Studies have found that mobile apps and online portals are cost-effective, easy to use, and provide patients with readily available access to information. This review focused on a number of areas of diabetes self-management, including diabetes education, healthy eating, physical activity, self-monitoring of blood glucose, and medication adherence. The authors outlined that whilst there has been a large increase in the use of health-related smartphone applications, there is actually limited evidence on its benefit and cost effectiveness. Studies that have shown improved glucose control, increase in patient satisfaction, moderate weight loss, and medication adherence with the use of digital tools have been found to be underpowered and of a short duration. One study, which was a large randomised control trial using a mobile phone-based self-management system for patients with type 2 diabetes, actually found no difference in glycemic control, self-management, health-related quality of life, depression, and lifestyle changes after the one-year intervention concluded. This article also highlights the current barriers to using digital tools for diabetes self-management. These barriers are 1. Cost. To use mobile health applications, the patient is required to have an expensive smartphone and internet plan. Internet access in developing countries and in rural areas can also be a barrier. 2. Insufficient scientific evidence. The majority of current literature available on the effectiveness of apps or internet-based tools are often of short duration and are underpowered. Larger randomised control trials are required of greater than 1 year to evaluate the real benefits of these tools. 3. The authors state that most available apps may actually not be useful for non-English speakers, the elderly, and those with a lower socioeconomic status. 4. Data protection and security is also a barrier. With the large amounts of data generated by digital tools, there needs to be more vigorous guidelines set to define who actually owns the data and where and how it is stored. There are also regulatory barriers. Improper use of these digital tools could have adverse health effects for patients and therefore need to be regulated by the appropriate governing bodies. App compliance with these guidelines need to be met before they are available for use. Overall, this article discusses important considerations for the use of mobile health applications for diabetes self-management. As highlighted by the other articles I have reviewed, further research needs to be conducted on the cost-effectiveness of these health solutions, and most importantly, more research needs to be conducted to determine if the proposed benefits of these applications occur in the long term or if they are only available to patients during the first year of use. This final article details the use of a national personally controlled electronic health record and self-management platform for patients with diabetes in Scotland. The My Diabetes My Way platform encompasses an education resource website, personally controlled electronic health record, patient decision support, goal-setting functions, social media functions including user peer-to-peer discussion groups, and a linked remote glucose monitoring system. Another feature of this system is that it can be accessed by mobile devices such as smartphones and tablets. Data for the personally controlled electronic health record component collates information from multiple sources, including the National Diabetes Disease Registry, laboratories, primary care records, prescribing sources, screening services, and secondary care information systems. Patients can also contribute to this information by adding data relating to their weight, smoking status, blood pressure, and either upload or manually enter blood glucose readings. Self-management information is also individualised according to the data. For example, foot care education is tailored to the entered foot risk classification. Patient surveys conducted have shown a perceived patient improvement in diabetes management, And surveys conducted with patients registered with the Scottish Diabetes Research Network indicated that 50% of those surveyed would like to access their health records online. However, despite these perceived benefits, the authors report that the usage of the platform has been low, with only 5.7% of those with diabetes registered to use the system. There has also been a lower use in older populations, lower socioeconomic groups, and minority ethnic groups. Reported barriers to use include difficulties with computers, not owning a computer, difficulties remembering passwords, and a lack of interest. Approximately 48% of those surveyed reported that they did not even know that the platform existed. Whilst the My Diabetes My Way self-management platform is a low-cost intervention with perceived patient benefits, it is yet to have patient buy-in and use despite a national advertising campaign. With its low usage, it is yet to demonstrate definitive clinical outcomes or cost effectiveness. The authors hypothesise that more proactive promotion of the program by healthcare providers may be the key to patient engagement, but they concede that for many people with chronic conditions, health management may come second to other priorities. And unless technology is accessible to those with disability, ethnic minority, and across the age and socioeconomic spectrums, it will fail to impact on population health outcomes. This article detailed that even with a well-designed self-management platform, stakeholder engagement from all involved parties, including patients, healthcare providers, and software developers, are required. Another downfall to this program not mentioned in the article is that patients with chronic conditions such as diabetes often have a large range of other chronic illnesses such as cardiovascular disease. The development of a personally controlled electronic health record should be multifaceted and not pigeonholed to suit just one condition. According to the 2016 mHealth App Developers Economics Report, the number of mobile health applications in 2015 increased by 100,000 to a total of 259,000 in 2016. This number is expected to continue to grow. However, literature is yet to show any long-term benefits in their use with diabetes self-management. These top 5 articles show that there are positive outcomes in the short term, and it is recommended that mobile health applications should be used to complement health provider consultation and not replace it. Mobile apps that have basic, easy-to-use functions should be favoured, and if possible, digital literacy support should be offered to encourage user motivation and engagement. Large cohort, long-term randomised control trials are required to assess the impact of mobile health applications on physical health outcomes related to diabetes self-management, and whether their use can complement the patient-clinician relationship, eliciting an improvement in the healthcare experience. More research needs to be conducted to examine the barriers to patient engagement, including behaviour change and the development of strategies to improve computer access and user computer literacy. Cost-effectiveness of mobile health applications in diabetes self-management also need to be analysed. Once some of these issues are addressed, I predict the use of mobile health applications can play a large role in improving outcomes relating to the components of diabetes self-management. Mobile health applications have a huge potential to impact healthcare provision for patients, particularly those who aren't able to readily access services. There is no doubt that mobile health applications will play a future role in facilitating self-management in patients with diabetes. However, based on current literature, we are yet to see how great their impact will be. These 5 articles provide an overview of available diabetes self-management applications and highlight important considerations for their use and identify areas for required further research. Barriers to use of these programs and other issues such as data management, legislative regulation and stakeholder engagement need to be addressed before their true impact on healthcare outcomes can be fully realised.